Hello, on behalf of AONN Plus and Eli Lilly Company Medical Affairs, we are pleased to welcome you to our Navigating Oral Therapy in Breast Cancer Practice Strategies to Promote Medication Adherence webinar. Please take a minute to review the disclaimer. This is an educational-only, non-CME activity, not intended to be promotional in tone or used to promote off-label products of Lilly. And also please note that this symposium is being recorded, both audio and video. My name is Jordan Henderson, Director of Program Development with AONN Plus, and I would like to introduce you to our three panelists that will present today. We have Maddie Kuiper, nurse practitioner with UCLA, California, Dr. Miriam Lustberg, Chief of Breast Oncology at Yale Cancer Center, Connecticut, and Dr. Robert Ferguson with the Division of Hematology Oncology at the University of Pittsburgh School of Medicine. The participants today will be able to describe the role of the nurse navigator within a multidisciplinary team in supporting medication adherence and persistence, identify modifiable factors associated with medication non-adherence amenable to nursing intervention, apply evidence-based psychological approaches to support medication adherence in clinical practice, and construct strategies to improve adherence and persistence in practice using a breast cancer case study. Again, this webinar is designed to facilitate conversations with patients regarding adherence to breast cancer treatment, with a panel discussion and a Q&A session at the end. Please submit your responses to our knowledge measurement questions on our Zoom platform. We will also have a Q&A and panel discussion session at the end, so please submit your questions to the speakers through the question function at the bottom of your screen. And also please use your QR code to provide feedback at the end. We will now start with our first presenter, Maddie Kuiper.
Good morning. Well, it's morning for me. Thank you. I'm sure it's midday for the rest of you. Thank you for having me here. Today we're going to talk about treatment adherence barriers and navigator intervention strategies. So let's get started. My disclosures are that I do work with Novartis and their Speakers Bureau and with Eli Lilly and Company as well. And then as we move on, let's test your knowledge. So we're going to make you work immediately. In a study of patients with breast cancer who continued treatment with adjuvant endocrine therapy for the recommended duration, what proportion of patients adhered to oral endocrine therapy? A, less than or equal to 60%, B, approximately 70%, C, approximately 80%, or D, greater than or equal to 90%. Please make your choice. And these are some of the things that we're going to be exploring today. So as we talk today, oral medication or oral anti-cancer medication use is on the rise. And I'm sure all of you that have been in oncology, even for as long as me, 30 years, or even in the last 5 years, will have seen the introduction of more oral anti-cancer medications. As you see on the left here, in the year 2000, we were looking at approximately only 7% of therapies administered were oral. Up until now, in 2018, we see now that we have about 40% of oral medications available. And with this, greater than 25% of 400 anti-cancer agents that were being developed in the United States in 2008, 25% of those were for oral medications. We also notice is that in the EU, that between 2000 and 2010, approximately 50% of targeted molecules approved were oral agents. So with this, we do see that advances in oral anti-cancer medication call for an increased need to address challenges that can be related to the use of oral medications so that we maintain patient safety and medication adherence. And as we go on, we look at the medications that we are currently using in hormone receptor positive breast cancer. Oral anti-cancer medications have been very prominent in this class of patients, and patients tend to prefer the use of oral medications over IV therapy due to its convenience, its perception of efficacy, and past patient treatment experience. A lot of patients will have had more oral therapies in their lifetime as opposed to IVs. In patients who have metastatic breast cancer, 76% of patients reported a preference for oral anti-cancer drugs over IV, and this is because it allowed them to continue on their daily life without having to come into an infusion centre all the time. And what we have seen, particularly in the last 5 years, is the increase in the plethora of oral medications for hormone receptor positive breast cancer, and here are the class of drugs. We have endocrine therapies, CDK4/6 and PIK3CA inhibitors, mTOR and PARP inhibitors, and the good old oral chemotherapy agents that we can work with. As we continue on, we look at the important part of prescribing and for patients to take medications is medication adherence and persistence. And medication adherence is the extent to which a patient acts in accordance with the prescribed interval and dose of the dosing regimen when they receive their medication. And then persistence is the duration of time from initiation to discontinuation of therapy. So are the patients, the number of days that patients actually take their medications. So complicators to this can be that there can be intentional non-adherence, and this is an active process where a patient decides that they're going to forgo their prescribed therapy and not take it. Or we have unintentional non-adherence, and this is a passive process where patients do not adhere to their treatment due to either being forgetful, careless, or sometimes circumstances are outside of their control. And these are some of the things that we'll be looking at today. Next, we have many barriers that can be identified that can affect medication adherence, and here you see some of them listed out. Some of these are not modifiable factors, such as demographics and system-related factors, and we've all seen some of those for our patients. There are also some modifiable psychosocial factors that we can assist with, and I think that's where we should be focusing and trying to improve. Things like patient-provider relationships, positive perceptions of medications, and the support to be able to help improve patient adherence and persistence. As we continue on, we talk about the challenges of managing patients with oral medications in breast cancer. And here are some older studies, but they show efficacy here, is that, despite the clinical benefits of oral endocrine therapies, medication adherence and persistence is still one of the biggest challenges that we have. And particularly because we know we're requiring patients to be on therapy for a good 5 years, if not longer sometimes. And what we see here is the rate of filled prescriptions that can decline over time. So when patients actually get their first prescription, who actually fills it? And then as time goes by, do we continue to see those prescriptions being refilled or dropping off? And what you can see here on the right is that the adherence rate for tamoxifen after 5 years is anywhere from 41 to 88%. An adherence rate for aromatase inhibitors is anywhere from 50 to 91%. The adherence rate is between 46 to 100%. There's always an overachiever. And then there's the persistence rate of actually completing therapy between 27 to 68%. So a vast range there in rates. And as we continue to follow on, non-adherence, there was a study investigating the relationship between adherence and persistence to adjuvant oral endocrine therapy. And we do know, we've got efficacy studies that show us that endocrine therapy is effective in reducing recurrence and metastatic occurrences in patients. And there was a study that was done in 2011 by Hirschman, which looked at Kaiser patients in Northern California. And what they looked at were who filled at least one prescription of oral endocrine therapy. And we see that 69% patients actually filled the prescription, 31% didn't. And then of those who continued to actually persist through therapy at 10 years, and there was an estimated 81% who continued therapy and 74% who discontinued therapy. And then, of course, with that adherence is then the improved estimated survival at 10 years if they took their medications was 82% versus 78% in patients. So oral endocrine non-adherence and non-persistent do affect mortality, and that's something that we need to try and improve on. Let's continue on. So medication persistence is a balancing act. And it's between quality of life on one end and then obviously wanting our patients to have a good quantity of life. A lot of things can impact that. We talk about here about side effects, risks of recurrence that's perceived by individual patients, quality of relationships with healthcare providers can impact social support, and patients' own medication beliefs will impact this outcome. Moving on, we will discuss interventions that we can address, and this will be further discussed. And in consideration of time, I don't want to spend much time, but obviously key points for us are building good patient relationships, providing education, and if suitable, exploring the use of technology. The ONS did develop guidelines, and this was to look at patient adherence and the use of oral anti-cancer medication. And from this, the panel suggested that there needs to be a risk assessment of adherence with patients, education on oral medication, as well as addressing adherence, and then also ongoing assessment of adherence, proactive follow-up, coaching and motivational interviewing. Unfortunately, there's not a lot of great evidence, so this is low to very low, and in their guidelines, there were no recommendations to use technological interventions. And moving on to finish up, the role of the nurse navigator can be a very, very key point in trying to manage adherence and persistence with patients. And what we see here is the role of the nurse navigator. And that is obviously a key point is the primary commitment to patients, providing education that is suitable to the literacy level of the patient, being culturally sensitive and inclusive, supportive with a holistic care plan, collaborating with every member of the family and the healthcare team, being maintaining psychosocial assessments and support, and key being a coordinator within the interdisciplinary team and facilitating appropriate referrals. Let's continue. So the key takeaways that I will go through here, the use of and preference for oral anti-cancer therapies is on the rise, and we will continue to see that. Despite the clinical benefits that we know about when we treat our patients, managing and monitoring these therapies is one of the key points that we need to address, as it's a challenge. Factors that can influence drug adherence and persistence are multidimensional, and that will be further discussed. And then, of course, the key roles that nurse navigators play in the multidisciplinary team and being able to help and support patients so that they are taking their meds safely and effectively. We'll continue to test your knowledge again. So in the study of patients with breast cancer who continued treatment with adjuvant endocrine therapy for the recommended duration, what proportion of patients adhered to oral endocrine therapy? We have A here, less than or equal to 60%. We had approximately 70% with B, C was approximately 80%, and D was greater than or equal to 90%. So the answer to, in a study of patients with breast cancer who continued treatment with adjuvant endocrine therapy for the recommended duration, 70% of patients were adherent to oral endocrine therapy. So you can see we still have a lot of work to do. So we're going to then move on now to our next presenter, and I'd like to introduce Dr. Miriam Lustberg, who's the Chief of Breast Oncology at Yale, and she will be addressing It Takes a Village to Manage Patient Care. Thank you very much.
Thank you so much, and thank you for joining. I have no relevant disclosures. So first, just like the previous presentation, we would like to start by testing your knowledge. All of the following are top psychosocial motivators for adherence to oral endocrine therapy amenable to nursing intervention, except A, medication side effects and tolerability, B, positive views on taking medication, C, provider-patient relationship, and D, socioeconomic status. If you could mark your selection, we'll come back to this question after this portion of the presentation. So let's talk about some of these factors. So it's a well-known proverb that it takes a village to raise a child. And I think similarly, it takes a village to take the best care of patients with breast cancer, with patients and caregivers, of course, being forefront and center. But all of us as healthcare providers, from nurses, pharmacists, physicians, social workers, advanced practice provider, oncology rehab, and so many more specialties, really work together to be able to provide the most comprehensive, holistic care. Next. So why are multidisciplinary teams so important in breast oncology care? We often provide very complementary and specialized skills and knowledge, and we all bring these tools to the table from our different training and experience. Breast cancer is rapidly evolving knowledge base, and it's very, very challenging for one specialty to know all that is relevant to the best care of our patients. Patients and families want this. They know the importance of multidisciplinary collaboration. How many times have you been asked, have you talked to other members of my team? I want to make sure everybody's on the same page. And then also equally important, our treatments continue to become more intricate with increased reliance on oral therapies, including targeted therapies that really require this type of expert multidisciplinary collaboration. Next. So let's talk a little bit about a common patient clinical situation that we may all see in clinic. This could be a patient with node-positive, hormone receptor-positive breast cancer that is essentially undergoing multiple modalities, including surgery, which can have its own complications, chemotherapy with its various symptom toxicities, radiation often adds additional toxicities. And then by the time that the patient has gone through months and months of therapy, that's when the actual endocrine therapy and targeted therapy portion is actually approached. So you can imagine that the patient has a built up of various symptom toxicities. He or she is probably very fatigued. It's helpful to realize just how much patients have gone through by the time they come to this juncture. Next. And so as we think about all the different factors that impact our patients and their adherence, it's also helpful to also think about the healthcare system itself, adding additional complexity. So if we click through, we can see additional factors such as treatment decisions, multidisciplinary team factors, scheduling. I just need it to be advanced so we can see these. And so all of these factors can impact. Psychosocial factors also affect oral therapy adherence, including the patient-provider relationship, showing a very strong association with patients' adherence to oral endocrine therapy, as well as positive beliefs and views about the medications. So these are top motivators that have been shown to impact patient medication adherence. Other psychosocial motivators include worry of recurrence, knowledge about the medication, and feelings of self-control or efficacy. Next. So as we think about multidisciplinary expertise on adherence, we can see that all of us play equal deferring sometimes, but important roles in helping support our patients. Nurses play key roles in education, follow-up, and expert symptom management. Physicians and advanced practice providers also play a role in education, promoting trusting relationships and addressing toxicities when they do happen. And pharmacists also play an important role in education, helping us identify patients who may be having trouble with adherence, for example, if they're not refilling their medications on time, and helping us think about different types of patient reminders. Next. There are also additional tools for providers to help identify barriers. One such tool is provided free of charge at the MASK website, where this tool actually helps assist healthcare providers in the assessment and education of patients receiving oral therapy, and takes into account factors such as patient adherence, the type of drugs, what their actual format or application is, disease characteristics, and treatment plan. And so this can be a helpful tool for you to use with your patients. Next. So even though I talked about various solutions, I think it's important to also acknowledge that there are various challenges that remain. Yes, we are a multidisciplinary team, but it's also important to always try to clarify as much as possible who is actually doing what, because sometimes our roles do overlap. An additional challenge is, how do we actually implement some of these interventions that we know are helpful in low resource situations with labor shortages that have been particularly compounded in this post-COVID era? And then, are there resource sensitive ways that we can utilize to help our patients, including using technology, navigators, and other aids? So in summary, I hope I have convinced you that breast cancer management requires really the multidisciplinary expertise of multiple groups. And these include nurses, pharmacists, advanced practice providers, and physicians. Close partnerships among these groups is of high importance. Things that we can take back right now today is trying to build trusted relationship between our patients and our healthcare teams. And this is actually a low-hanging fruit that has been shown to be an essential component of improving adherence and persistence to oral cancer therapies. Still, more work needs to be done, including additional research on how to optimize and implement better care delivery and care coordination. And these body of work are ongoing. So in summary, it really does take a village to take the best, most comprehensive care of our patients. This is a beautiful village in the edge of Santorini, Greece. And it's many winding labyrinth of pathways. And in some ways, it's similar to our healthcare system. In its best form, the multi-D teams are lights along these pathways, helping our patients navigate this complex journey. So coming back to our test your knowledge question, all of the following are top psychosocial motivators for adherence to oral endocrine therapy, amenable to nursing intervention, except A, medication side effects and tolerability, positive views on taking medication, provider-patient relationship, and D, socioeconomic status. And the right answer is that the most modifiable risk factors and motivators are the top 3 that are listed there. And these are things that our nursing colleagues have particular expertise in, and these very much impact oral adherence. With that, I will pass on the baton to my colleague, Dr. Ferguson. Thank you so much.
Okay. Thank you, Dr. Lustberg, and thank you, everybody, for attending today. For my disclosures, I do have one disclosure that's peripherally related. I have a book and a survivor workbook on the cognitive behavioral treatment of memory problems in cancer. And we want people to have functional memory to help remember when they're taking medicines. I'm also a speaker for Eli Lilly and Company. Next slide, please. So to test your knowledge, our question for this segment is the following, and I'll give you time to mark your answer, which is, what is not a core skill needed for motivational interviewing? A, asking open-ended questions. B, affirming the patient's attempt to change behavior. C, reflecting and understanding patient's thoughts and feelings. D, evaluating patient's decisions. And E, summarizing of patient statements. What I'm going to talk a little bit about today is, first, some of the patient-related individual psychological factors that influence adherence to oral cancer therapies. We've already talked about sort of the overview of the adherence problem, the scope of it, as well as healthcare system factors, as well, and doctor-patient relationships. But when it comes to individual patients and working with patients as a nurse navigator, I'd like to have you think of 3 categories of behavioral factors that can influence adherence. And note that these categories are not mutually exclusive. There is some overlap. And these are demographic factors, health risks and perceptions, and psychological and psychosocial and cognitive factors. Under demographic factors, just some highlights quickly. Older and younger patients may differ in their adherence to medications based on age, and this may have to do with medical comorbidities among older patients who already have complex medical regimens and may be on multiple medicines. Now we add an oral cancer therapy that may or may not have a complex regimen, but in the scope of that person's entire health, it may be overwhelming. Younger patients, by contrast, may not have experience with chronic illness and may not have an appreciation for the scope of their illness or misconceptions about the seriousness of it. Race factors are important with adherence, and there is this notion of medical mistrust, and this is generally in African American populations higher than their Caucasian counterparts. However, I caution people against overgeneralizations because medical mistrust also depends upon, and it can be stratified by variables such as rurality, living in an urban setting next to a comprehensive cancer center versus in more rural settings, or it could be stratified by the complexity of the disease and the treatment and acceptability of the treatment. We know, for example, people who live in rural settings, whether or not they belong to an ethnic minority category, that once individuals in those settings are asked to participate in cancer clinical trials, for example, they participate at the same rates as individuals living closer to urban settings and comprehensive cancer centers. And that's research by Unger out of the Fred Hutchinson Cancer Center in Seattle. Moving on to health risks and perceptions. Can we go back to the previous slide? I'm going to go over each 3 categories here. With health risk and perceptions, having a family history of cancer can lead people to have a greater appreciation for the risks of cancer and the symptoms and side effects of what to expect of certain therapies and oral therapies. Individuals who use alcohol and cigarettes, there's exceptions to the rules, but they may have lower risk perceptions of using substances than individuals who don't use that, and that can affect adherence. And individuals have greater positive or negative concerns about the medication. Certainly a positive outlook and trust with the medical oncologist and medical oncology team is usually associated with better adherence, and worse adherence with the opposite, those individuals who mistrust the team or have great concerns about the symptoms, side effects, or adverse risks of the medication. Going over to psychosocial and cognitive factors, certainly lower social support. Individuals who live alone may not have simple reminders by loved ones with whom they live to stay on their regimen and keep up with the dose density and the persistence of taking the medication. Individuals with higher depression and greater helplessness or hopelessness may not see the point in going on with the therapy, particularly if it has a high side effect profile. Individuals who are anxious, there are two factors within anxiety that are important to keep in mind when you assess patients and you meet them for the first time. One variable is intolerance for uncertainty. Many people with generalized anxiety disorder are not even meeting criteria for that disorder who have high amounts of worry and seek reassurance, often with a lot of questions about the risks of medication, and who are not very tolerant of the uncertainty of taking the medication may have lower rates of adherence. Individuals high in anxiety sensitivity. Anxiety sensitivity is this psychological factor that reflects tolerance of the physiological symptoms associated with arousal and anxiousness. And usually this is associated with lowered tolerance for adverse or uncomfortable side effects of medicine. So and these things are quite modifiable, anxiety, depression. So this is something to consider. Underlying all three of these buckets of common patient factors that influence adherence is symptom side effect burden. Next slide. Thank you. When you look at all oral therapies, and this survey that was done a few years ago by Jacobs and colleagues at Mass General Hospital up in Boston, fatigue, drowsiness, the energy-related symptoms are the most frequent reports of adverse side effects of all oral agents put together across all cancer types. Memory problems is also highly rated. Next slide, please. When we shift to oral endocrine therapies, the number one symptom that's reported as being bothersome and that can motivate people off or to take a holiday from the medication is myalgias and arthralgias. Hot flashes and sleep disturbances are high among this, as well as cognitive impairment. Aromatase inhibitors and tamoxifen can be associated with reduced verbal memory as well as processing speed and short-term memory, so remembering conversations that might have taken place several hours ago. That can also lead to getting out of a routine and skipping a step in the morning routine that may include taking a daily dose of endocrine therapy. So be aware of these symptoms and side effects that could influence in a number of different ways adherence and persistence to the oral therapy. Next slide, please. I wanted to just briefly touch on the general evidence for individual interventions that have been trialed over the years for adherence. And if you look at the lower left part of this slide, you can see 3 reviews that are worth taking a look at. And the conclusion of those reviews are that the evidence of being effective for improving adherence as measured by pill cap monitoring systems or medication event monitoring systems, which is electronic opening of the pill. We still don't know if the individual took the pill, but the cap was opened. We can assess adherence that way. But the outcomes aren't very good long-term on these interventions. Some of the reasons that these review authors have cited that the interventions aren't that helpful for long-term adherence to oral therapies include that some of the treatments were non-theory informed. They didn't engage stakeholders or patients and nurse navigators and medical oncologists in the design of the treatments. And the treatments tend to be unitary in nature. So one method, it might involve text messaging reminders or phone call reminders. But we do know that multi-strategy interventions usually end up with a higher likelihood of adherence than single strategy interventions. So for example, we may design treatments that target symptom and side effect self-management, also education about disease and how the oral therapy works in preventing recurrence or adding to overall survival or progression-free survival. And some interaction, if there's a technology-based and multimodal intervention design, Nurses and pharmacists that have an interaction with the patient rather than one-directional communication tend to have better efficacy. Next slide, please. Now, I'm showing you this slide with a little bit of data of outcomes of an adherence app that was designed, I think, roughly around 2014. And it involved some symptom monitoring, as well as education, as well as communication with a nurse navigator. And again, they got this outcome of, well, their standard care group really didn't differ from the mobile app group on outcomes. But if you look at a subset of individuals, those people who had adherence problems, which is the top row of data, those people had adherence problems at baseline that were in the lower quartile or the lower third of adhering to their oral therapies. They did better in the mobile app group because the specific behaviors were targeted. But also on the second line, individuals who had higher levels of anxiety as assessed by the hospital anxiety and depression scale, those individuals who scored above 7 did much more poorly than the individuals who had lower levels of anxiety. My point here is that maybe that when we target specific patients with specific factors that can influence adherence, we're doing much better than having an intervention that's designed for all comers on all oral therapies. So it'd have to be a little bit of tailoring of the intervention. Next slide, please. And these are outcomes of the symptom-targeted randomized intervention for distress and adherence. That's a mouthful, but this is a 6-visit cognitive behavioral therapy, again by Dr. Greer and colleagues up at Mass General. And this 6-visit cognitive behavioral therapy is completely done remotely. It's designed for telehealth intervention. And they found that they didn't get a statistically significant result in patients that were randomized to STRIDE versus medication monitoring as usual on adherence. But there was about a 5 to 10% improvement in adherence. So it might have been a clinically meaningful improvement in adherence. But here again, when you look at the outcomes of symptom distress, quality of life, coping skills, anxiety symptoms, all of these improve significantly in the STRIDE intervention versus the medication monitoring intervention. So being aware of symptom distress, anxiety, and tailoring the intervention for those factors, as well as other factors such as persons living alone, low social support, or if there's medical mistrust, identifying those factors and helping tailor these interventions that have been trialed and continue to be researched might be helpful. And you can draw from some of these interventions to use in your own practice in navigation. Next slide, please. So what can you do to help patients adhere to oral therapies in the here and now? I just boil this down to 2 things: assess and assist. What I mean by assess is use those 3 categories I put in the previous slide. Demographic factors, health perception, health risk perceptions, and psychosocial and cognitive factors. Ask questions about that. Or when you're reviewing the medical record of the patient, you can identify some of these factors before you even meet with them. And in the assist portion, you don't have to be an expert or somebody who's a master of motivational interviewing, although I think most nurse navigators are the best motivational interviewers I've ever heard. But there's these 3 principles of a collaborative relationship. This is a joint venture between the healthcare professional and the patient of identifying the pros and cons of being on these oral therapies and coming up with strategies, whatever it takes, for adherence and persistence over time. The acceptance square in this slide really refers to be accepting and not judgmental of the person's ambivalence. Ambivalence in any decision human beings make is really normal. And sometimes there's a no-brainer. It's about in 99% pro to 1% con in some decisions we have in life, but most of us clump up around the middle, and there's cost to any decision that we make. Be accepting of ambivalence to being on oral therapies is normal. And then evocation just has to do with help engage the patient in a discussion about their own perceptions of the costs and the benefits of being on oral therapy. And usually patients will come up with their own solutions to adhere to daily or whatever regimen that they have for oral therapies. Next slide, please. And this is just a summary of the same sort of motivational interviewing skill, asking open-ended questions. So the person can't say yes or no to them. And affirming that the person's trying, at least coming into the office or engaging in that telehealth visit about some of the problems that they're having adhere to oral therapy, or asking questions about their concerns about potential adverse effects or bothersome side effects, and reflect of the person's thoughts and feelings about that. And that would be a simple thing. So I can tell you're frustrated with your hot flashes. And then summarizations are longer summaries of a patient statement. And that might be something like, well, I understand that you're concerned about hot flashes, but on the other hand, you've told me that you want to stay on your endocrine therapy because you want to reduce your risk for breast cancer. And you thought that getting just a simple pill organizer was a first step. Tell me more about that. And then that starts the conversation of real world solutions to adherence. Next slide, please. Another toolkit you can go to that's updated periodically is the Oncology Nursing Society Toolkit of Adherence. And it's available in the website indicated at the bottom of this slide. Next slide, please. And if you want to see the STRIDE manual, I would suggest going to this reference in this slide. And this is the symptom-targeted randomized intervention of the stress and endocrine therapy adherence. Next slide, please. So some key takeaways here. Think about when you assess individual adherence problems with patients that there are common patient factors that affect adherence. And that can go into three buckets: demographic factors, health risks and perceptions, psychosocial and cognitive factors. And keep in mind that symptom and side effect burden can cut across all three. And when you interview patients and assess for potential barriers to adherence, you can keep those points in mind. And then assist using motivational interviewing, and then that might lead to some of the interventions we discussed here in helping the patient use parts or components of that to maintain their adherence to oral therapies. Next slide. Okay, here's the test your knowledge quiz. What is not a core skill needed for motivational interviewing? Asking open-ended questions, affirming the patient's attempt to change behavior, reflecting and understanding the patient's thoughts and feelings, evaluating patient's decisions, or summarizing of patient statements. Evaluating a patient's decision is really not a motivational interviewing skill. That would probably incur a bit of judgment. That's not a cardinal sin. However, you want to reflect the person's costs and benefits that they're telling you and help them identify ways around that to reach their goals of reducing their cancer risks.
We will now begin our panel discussion with our breast cancer case study. So our case study, we have a patient named Tina. She's 52 years of age, perimenopausal. She's the owner of a paint store and primary caregiver for her father. She's married with 3 adult children. She's got a history of type 2 diabetes. Her mother did die of breast cancer. She is hormone positive, HER2 negative, metastatic breast cancer with visceral mets. The patient did meet with her family and her healthcare team to discuss her treatment options, and the patient is going to start treatment with oral endocrine therapy plus a CDK4 and 6 inhibitor. She does have concerns about side effects and cost of treatment. So now opening the discussion up to our panelists, Dr. Lustberg, I'll start with you first. If Tina were your patient, what barriers to treatment adherence would you anticipate, and what would you discuss with her as she was initiating treatment, really regarding that first month of treatment?
So yeah, this is a very common clinical case presentation that we see in practice quite frequently. So I think she has already voiced concerns about symptom burden as well as financial toxicity. So I think taking time to answer her questions about what to commonly expect from these classes of drugs, I think would be important, and different strategies that we have for symptom management. And then really explaining that there are different resources available for financial assistance and coverage of these drugs. I would probably spend most of the time talking about her top 2 concerns, and also emphasizing the biology of her hormone receptor positive breast cancer and why the CDK4/6 inhibitors are thought to be beneficial, so that she has a good foundational understanding of why she would take on such a therapy.
Thank you. Maddie, from the Navigator perspective, how does your multidisciplinary teams work together to ensure patients adhere to therapy? And then what is the role of the nurse navigator?
Hi. So, the ultimate goal is the nurse navigator in my practice is me. So I'm an NP/nurse navigator. Ideally, I would love to have my own separate nurse navigator who could spend more time with patients. So I think the key role here is, making sure that they understand the therapy recommendations from the physician or the provider's recommendations, and then looking at how they can assist the patient in being able to take medication that meets their needs while addressing all of the potential factors that could impact that. And for Tina, she has quite a few impacting factors here. So, helping sort that out, working with supportive providers within the rest of the healthcare team, and helping maybe negotiate between providers, particularly depending, if there were issues or concerns about drug interactions, or if there were concerns about how to get hold of medications. And I think the other key role that the navigator can provide is easy contactability. I find that is one of the hardest things for patients, that when they have a question, being able to address it and as promptly as possible, and actually having the time. I think the navigator role is a prime position to be able to follow through with patients and to address issues as they start occurring and coming up, and doing more of a follow through apart from just, a scheduled visit that may be in, if you're lucky, in a month with their provider. So I see their role as key in this, and also helping to highlight any issues that occur and come up that they may not feel comfortable discussing with their provider. So,
thank you, Maddie. Dr. Ferguson, I'll come with you next. If Tina returned in 6 months and stated that she has been taking the medications, that taking the medications weren't worth it for her, how would you respond?
This is a great case study. Well, when somebody comes back with discouragement from the medications, and it's not cost barriers, because Dr. Lustberg and medical oncologists are great about finding ways to help finance medications. I would look at her history. Does she have any history of mood or anxiety disorders? So if that's the case, particularly being perimenopausal, now you're going to go on endocrine therapy in addition to a CDK4. You want to make certain that, are we doing what we can to manage mood well? And there are evidence-based cognitive behavioral therapies for depression that are outstanding, and they're highly efficacious, and they're short-term and they're to the point. So I want to rule out if there's any history of depression, and could this stressful life event also push her back into a major depressive episode. In addition, the same thing with anxiety. 60% of the time when a patient presents with a major depressive disorder in the medical service, there's also a history of coexisting anxiety disorder. So identifying which anxiety disorder it is, if it's generalized anxiety with worry, then we'd want to address that to help her reduce her worry and concerns about the medication therapies and going on. And it looked as though that this was a visceral metastasis, so she may have concerns about mortality, and we'd have to address that in some sort of evidence-based cognitive behavioral therapy format.
Thank you. This one I will direct to both Dr. Lustberg and Maddie. How would you respond if Tina stated that she took the medication when she remembered it, which was generally most days of the week? Dr. Lustberg, I'll start with you.
So I would first thank her for telling me, because I think much data suggests that patients actually don't feel safe reporting adherence and persisting issues to their providers. They don't want to feel shamed or made to feel guilty. So I would really just make sure that she knows that this is a welcoming environment, and then try to probe further in terms of what's leading to this behavior, and if there are, and depending on what she says, kind of thinking of different strategies, whether it be reminders, or is it concern about toxicity or some other reason, just trying to understand better through open-ended questions, as Dr. Ferguson mentioned, to really understand what the issues are.
Thank you. And Maddie?
Yeah, and I think, from a nurse navigator perspective, in working with a provider, is understanding, like you say, what are the barriers that are impeding this patient from deciding to take her medications every day versus, a couple of times a week or whatever it is maybe as the nurse navigator, you can do some more follow up a little easier, maybe meeting with the patient once a week, and then also trying to address the barriers and maybe linking to providers or other services that can help break down some of those barriers for the patient. And it may be that, some of this is, she's the sole carer for an elderly father, and his needs maybe are outweighing her needs, because women are terrible at, focusing on their own needs. And, maybe that is some of the things that we could be working with, and addressing her own, what's going on up in her head here, because, there's not always a pill for everything. And that can be one of the hardest things for patients to get their head around, is looking after themselves as just as much of a priority. And I think that's a great role for the nurse navigator, and being able to link up there.
Thank you both. Now let's move our discussion to the audience and see if we have any questions from them. It looks like we do. It says, how do you manage a patient who want to use concurrent hormonal replacement, so bioidenticals, with aromatase inhibitors, or who would prefer the more holistic route because they experience severe menopausal symptoms prior to breast cancer? Dr. Lustberg, would you feel comfortable speaking to that one?
Sure. So it's a very important question. This comes up quite a bit in our oncology practices. If we went strictly by evidence-based medicine, studies have shown that exogenous hormones, whether they be bioidentical or not, do increase the risk of breast cancer recurrence and hormone receptor positive breast cancer, but not hormone receptor negative breast cancer. There was a recent meta-analysis that was published on the topic. But typically the patients who present in such a way have very strong opinions, and they do shut down very quickly if the provider is very instantly dogmatic about things. So I do try to spend some time listening and trying to explain the rationale, trying to offer additional non-hormonal options for symptom management and menopause. If it's more sexual and genitourinary symptoms, we actually do have some safety data for more topical-based vaginal estrogen therapies. So kind of understanding where she's experiencing the most trouble in terms of postmenopausal symptoms would also be important. And lastly, I think the most dangerous thing that could happen here is if they feel completely unsupported, they can actually stop all their follow-ups within oncology. So really kind of giving the message that even if we may disagree or that I have strong reservations about her combining her existing breast cancer treatment with such therapies, still emphasizing that she could continue to follow up with me and we could potentially have additional dialogues about this. So kind of keeping the lines of communication open. But the evidence-based answer is that it is not recommended.
And then to follow up on that, Dr. Lustberg, would you address patient adherence differently for an early breast cancer patient versus a metastatic breast cancer patient?
I've been thinking about that, and I think making sure that the goals of therapy are understood within each setting, where in the early stage breast cancer, we have curative intent still as a possibility, and metastatic breast cancer is disease control and palliation. I think adherence and persistence are equally important in both, but I don't know if I would necessarily address it differently, but really kind of coming back to understanding their challenges, understanding their reservations. Both can be on the same therapy sometimes for years. So they actually, I think, share more similarities than differences.
Thank you. And I think we have time for one more question. Maddie, what are the most impactful strategies that you have used in your practice to address patient adherence when they are experiencing side effects? And then again, how can nurse navigators help support them?
Yes, and I think, sort of working off what Dr. Lustberg just talked about is that, yes, there will always be potential side effects for patients. And I think, because the patients are going to be on these therapies for extended length of time, in the early setting, at least 5 years, if not longer. And in the metastatic, setting, it's a chronic disease now. So, being able to support those patients. Some of the things that I've done, particularly myself, is when I am prescribing a new therapy, be it in the early or the metastatic setting, is I do we help with shared decision making and helping patients come to their decisions to do therapy. And then once they actually receive their therapy is when I have, and they physically get it in their hand, because most of this is all send out insurances, is that I ask the patients to call me and we set up another time to be able to sit and talk and do education and utilize online resources, things like that, be able to address potential side effects, the things that we can do to mitigate some of those side effects. And often that is also a time where we actually do come up with some barriers that the patient feels comfortable talking about and how they can manage it. But then I will also do, and this is where I would love to have my own navigator with me, is, like a weekly follow-up. Honestly, I unfortunately get lost with, constantly having to see patients, that this can impact my ability in direct follow-up as opposed to addressing questions as they become issues. So I think that's where a key point is for the navigator, is being more of the proactive and being able to address issues before they currently arise. And still, sometimes when I get them, when, oh, there is an issue, I have this side effect.
Thank you. So that is all the time that we have today. Please remember to complete your evaluation from using the QR code that you can see on your screen now. You will also be able to view this webinar on our John's website in the coming weeks. I want to thank again our three panelists, Maddie Kuiper, Dr. Lustberg, and Dr. Ferguson, for your insight and discussion. And on behalf of AONN Plus and Eli Lilly, thank you to all of our participants today.